Okay, good afternoon, all my colleagues, my professors, and in Egypt. First of all, I want to thank European company for inviting Professor Fabio Medolla and me for discussing one of the very important and current about the COVID-19. I will introduce one of the well-known figure worldwide, Professor Fabio Medolla. He's a full professor of pediatric, director of pediatric emergency in Piacenza University of Rome. He was the president of the Pediatric Assembly of the European Respiratory Society, and he will be the next president of the Italian Society of Pediatric Respiratory Disease. Welcome, Professor Fabio.
Thank you.
Please, we are waiting for your presentation about the COVID-19, and you can start now. Yeah. Okay.
Do you have first to share and then to open? Okay. Just a second. Share the screen. Okay. Did you see it? I can start? Okay, so good morning to everybody, and thank you very much for the invitation, and thank you very much for the nice presentation made by Nader. I'm really very happy to be with you today. Probably I would like to be in Egypt instead of staying in Rome, and I miss very much my last visit in your country. So we know that in all the world we are now fighting against COVID-19. During my presentation, I will do a brief introduction. I will speak about the source of COVID-19, epidemiology, etiology of pathogenesis, symptoms and diagnosis, COVID-19 in children, the problem with mother and fetus, and I will say something about what we know about the treatment. So we all know that the first cases of unexplained pneumonia in China were in December 2019. On January 12, the World Health Organization named this new virus 2019 COVID. On January 1st, the World Health Organization announced 2019 new coronavirus epidemics, a public health emergency of international concern. And on the 11th of February, the World Health Organization formally named the disease COVID-19. And on the same days, the coronavirus study group named the 2019 new coronavirus as a severe acute respiratory syndrome coronavirus 2, SARS coronavirus 2. How do we go? How can I go in? I have to go to change slides. I do it. Okay, here it is. At the end of January, the first pediatric cases have been reported, ranging from 112 days to 17 years. And on February 23, 2 months later, after the first cases of lung pneumonia, there were more than 70,000 confirmed cases of SARS coronavirus 2 infection in China. And officially, on March 11, the World Health Organization established a pandemic of the virus. And now we know that this is the third known zoonotic coronavirus disease after SARS and Middle East respiratory syndrome. We know that the cases of COVID-19 infection were related to human seafood market, and it was established a possible human-to-human transmission that could not be ruled out. We know that the virus is a chimeric virus, and it is a similarity is between a bat coronavirus, and a coronavirus of unknown origin. Snakes are the most likely wildlife repository of the virus, and the current evidence strongly supports that SARS-CoV-2 derived from bats, although the intermediate hosts remain to be determined. I don't know if you heard that at least in Italy, in some newspaper and in some movie in the television, it was reported that the possibility of a genetic manipulation of the virus in the laboratory. And in March 17, it was published a paper in Nature Medicine Date, where they rule out the evidence that the virus was a laboratory virus, so it's a natural virus. I move myself, I don't move the screen, this is the problem. Okay, so this slides report is a slide of April 8. You know very well that every day the number are changing. So this is one of the last data on the number of cases around the world, the number of deaths around the world. As you can see, Europe is in the first place. Europe is the country with the most, with the higher number of infected patients, and with the higher number of death patients from coronavirus infection, followed by United States, Asia, and you can see on the left there is a small number of patients in Africa, and the rate of death for this disease is around 6%. There are 81,478 deaths on 1,391,890 patients. Here are some data of a specific country. You see that Italy is in the first position. We have, on the 8th of April, we had more than 135 cases with 70,000 deaths, followed by Spain, and at the end there is a data about Egypt, and I'm sure that Nader will tell you about the situation in Egypt. For the European Center for Disease Prevention and Control, on the 8th of April in Egypt there are 1,322 positive patients with 85 deaths for coronavirus infection. There is also something that came out about the latitudine of the disease. It appears that this infection is more common in the world regions that match a specific set of climate condition, and mainly in a climate of a temperature between 5 and 11 degrees Celsius, and an average humidity between 47 to 79%. So this is the reason why the most affected regions are China, South Korea, Japan, Iran, north of Italy, New York, Seattle, and North Carolina, because they are between the band of 30 or 50 degree north latitude. And this is in this slide, you can see which is the latitude that the countries that are in the middle between the 30 and 50 latitude north hemisphere. and this is probably the reason. I mean, this is what they say. The reason why this virus is less frequent in countries that are out of this band of north latitude. These are some of the data that come from Italy. These data are updated on the 6th of April. You see it on 6th of April. We have almost 132,000 patients. What is important, I would like to underline that 40,000 are the doctors, nurses, and people that work on the hospital that are being infected, because there is we have a problem with the mask and dress to prevent infection. And on the 6th of April, we have 16,000 of deaf people. You can see that the mean age of our cases in Italy is 62 years of age. And on the right, you can see in the table that most of the deaf are among patients that are from 70 to 90 years of age, and this group of patients represent almost 80% of the patients that died, and the median age of deaf people is 8 years of age, and the mean age of infection is from 60 to 62 years of age. Here is reported the incidence of COVID-19 infection in Italy. You know that the shape of Italy is like a big shoes, and you can see from this slide that most of the cases are in the north of Italy. We really don't know why this happened. We think because the restriction measure at the beginning was not followed very well in the north of Italy, probably because of the air situation, air pollution, weather, or also because the density of the population is much higher in the north of Italy than in the south. You can see my region, that is Lazio, and Lazio had 3,900 patients. So there is really a wall between the north of Italy and the center and south of Italy. And here are reported the absolute number of deaths for age of the patients, and you can see that in Italy, most of the deaths were in patients over the age of 60, and you can see also the difference between men and women. Women are the red bar, and the men are the blue bar. So this disease is much more severe in men than in women. And I'll go on. And here is reported also another very interesting set of data. You probably know that people that died mainly have comorbidity. And if you can see in the table, I report the difference between women and men. But if you see all patients, the most important comorbidity for a severe COVID disease are heart comorbidity, like ischemic heart disease, atrial fibrillation, heart failure. And what is very interesting, most of the patients that died have blood hypertension. Another comorbidity that is important is type 2 diabetes, chronic renal failure, and 10% of the patients 10% of the patients that died had obesity. And on the bottom of the table are reported the rate of the number of comorbidity in the people that died. And you see that if you have only 3.3% of the patients that died have no comorbidity, 14% have one comorbidity, 20% have at least two comorbidity, and 61% had at least three comorbidity. So, in conclusion, female seems to have a more robust immune response to this virus than in male, probably because hormones, but we don't really know that. The disease progresses much faster in the healthy population, and the fatality rate that in Italy is around 6% is higher in patients with underlying disease, including diabetes, hypertension, and cardiovascular disease. And if we compare the fatality rate of this or COVID-19 is a little less than SARS and MERS that were 9.6 and 35% for MERS epidemic. Yes. Okay, so how does the virus spread from person to person? Is a respiratory virus, so the mechanism are very similar to other common influenza viruses. So face-to-face contact, sneeze or cough, and contact with secretion of people who are infected. And these are very important for prevention. And what has been demonstrated that there is also fecal oral transmission is very important for this virus, especially in children, because there is a study that shows clearly that you can find the virus in the feces many days after the virus has disappeared from the nasal and pharyngeal swab. Okay, now we move to the etiology on the pathogenesis. We all know that there are 4 coronavirus that are very mild viruses that go around in the human population. Then there is a virus of MERS, of SARS, and then this new novel human coronavirus that has been named 2019 new coronavirus. It is a RNA virus with a spherical shape, and it has been demonstrated this virus has a 78, almost 90% of similarity with bats virus and with the SARS. This is a picture of the virus. You see the spherical that is a spherical shape. You see the protein to the surface, and the most important protein for the attachment of the virus is the S protein. And all the genetic tests are directed to the gene that code for the S protein, the HE protein, and N protein. We know that the virus can stay up to 3 hours in paper, 4 hours in a cooper, 24 hours on cardboard, and more than 24 hours on plastic and stainless steel. We know that we can kill this virus with ethanol, hydrogen peroxide, sodium hypochlorite in just 1 minute, but benzalkonium chloride and chlorhexidine is less effective. How does the virus, which are the receptors of the virus? As I told you, most of the study on this virus come from the study on SARS, but there are also some evidence that the specific receptor for SARS-CoV-2 is the angiotensin, are the angiotensin converting enzyme. These receptors are expressed in type 1 and type 2 alveolar epithelial cells. Most of the receptors are expressed in type 2 alveolar cells. We know that men had a higher concentration of these receptors in their alveolar cells than women, and this could be probably a reason why men had a more severe disease than women. We know also that Asian people have a higher level of ACE2 expression in their alveolar cells, and white has more receptor than African American population. We know that so the virus bind to these receptors that can lead to damage on alveolar cells, and after the virus bind to ACE2 receptors, there is a series of systemic reaction and even death. We know also that the binding ability of SARS-CoV-2 is 10 to 20 times more stronger than that of SARS-CoV, and this is the reason why probably this virus is much more infectious than the other two coronavirus. We'll go back to ACE2 receptor when we speak about children. What is evident from the literature that there is a subgroup of patients that have a severe COVID-19 infection that may have a cytokine storm syndrome, because they measure the cytokine concentration in the bronchial lavage of these patients. We know that acute respiratory distress syndrome is the leading cause of mortality of COVID-19 patient, and we also know that there is a syndrome that is the hemophagocytic lymphohistiocytosis disease, that is an hyperinflammatory syndrome that is characterized by a fulminant and fatal multi-organ failure. And we know that in adults, this syndrome is most commonly triggered by a virus infection. And this is to tell you that the hyperinflammation that you have in COVID patient with severe disease is very similar to the symptoms that have the patient with HLH. And this is the reason why when you have a patient with severe respiratory distress, you should screen for hyperinflammation in the lung, and you have a therapeutic option to use steroid, intravenous immunoglobulin, or to use a selective cytokine blockade with tocilizumab, that is a specific monoclonal antibodies against IL-6 that is normally used for patients with rheumatoid arthritis. And there are several studies that are going on in Italy on a severe patient with COVID-19 with this medication, but we don't know yet which are the results. So I think that you all know which are the symptoms of a patient with COVID-19 infection. You can have respiratory symptoms that are the most common, like rhinorrhea, sneezing, sore throat. You can have pneumonia with ground glass opacity, or you can have an acute respiratory distress syndrome with a cytokine storm on the lung. But you can also have systemic symptoms like fever, cough, fatigue, headache, hemoptysis, acute cardiac injury, hypoxemia, dyspnea, lymphopenia, and diarrhea. And what is typical of disease is the presence of diarrhea and gastroenteric symptoms that were not present in SARS and MERS patients. And this is the reason why we think that it's important to test, to check the virus also in the feces and in the urine. These are, here are reported the symptoms, and the most common symptoms are fever, and usually they have a high fever over 38 degrees Celsius. 76% of the patient may have cough, dyspnea, muscle pain, head expectoration, headache, hemoptysis, and 3% of diarrhea. So it's important to rule out that also in this patient, also with a lung disease, they may have diarrhea. So mainly we have three major patterns of the clinical course of the infection. You can have a patient with a mild illness without with upper respiratory tract presenting symptoms. You can have a group of patients with pneumonia, but it's a non-life-threatening pneumonia. And you can have a group of patients with severe pneumonia with acute respiratory distress that begins 7-8 days after the onset of mild symptoms, then can progress to rapid deterioration, RRDS, and they need advanced life support. So the incubation period of the disease range from 2 to 14 days. mostly from 3 to 7 days. The disease started with fever, cough, that can be accompanied by chest discomfort. At this point, you can have a group of patients that have a gradual resolution of symptoms, or you can have a group of patients that can proceed to cough, chest discomfort, and aggravation in 3-4 days. And from here, they can have a resolution of the symptoms, or a small group of patients can go to respiratory distress 7 days after the onset of symptoms, and worsening usually in the next 2 days. And the period between the onset of COVID-19 and the symptoms to death range from 6 to 41 days, with a median of 14 days. These are the most common laboratory tests that you can find in adult patients with COVID. 25% of leukemia. There is a positive correlation between the number of lymphocytes and the severity of disease. 63% had a lymphocytopenia. They can have a mild increase of liver enzyme. C-reactive protein and procalcitonin usually are not increased. They can have an increase of muscle enzyme, LDH, myoglobin, D-dimer, and the increase of myocardial enzyme, because, as I told you, there is always a myocardial involvement. Chest X-ray is can have in early stage, you can have a finding of multi-small patchy shadows or interstitial change. In severe cases, you can have bilateral multiple ground loss opacity, and a CT scan, high resolution CT scan is positive in 98% of patients with severe disease, and ground glass opacity and consolidation area are the most common, and it's what you can see in this CT scan of a patient with the COVID-19 infection. And what is also very typical is the finding on ultrasounds. You can see these are B lines. B lines means that there is an increased water content in the lung, and is a typical finding of patient with lung interstitial lesion, and is a typical finding of patient with COVID-19 interstitial lung disease. We use in Italy very often to follow this patient and to make the diagnosis ultrasounds, and is a technique that now is using very often. And of course, the interstitial lesions are confirmed in all the patients with the CT scan of the lung. Also, how do we make the diagnosis? There are 3 methods to make the diagnosis. The most common, and that the one that is used in all the lab in Italy, is reverse RT-PCR, that is looking for viral gene sequencing on nose, throat swab, sputum, stool, or blood samples. You can also isolate the virus from human respiratory epithelial cells, but this is not a routine test. And now they are coming out a lot of immunological tests where you can look for a specific IgM and IgG antibody. But I think that is more important, it will be more important in the future for epidemiological study. At the moment, the test that is used is the PCR on the nose and throat swab. Remember that the sensibility of this test is not too high. It is from 40 to 60%, whereas the specificity is almost 100%. So now we move to children. We are pediatrician, and probably this is the most interesting part of the talk for us. And here are some data that come from Italy, where it has been demonstrated. You see on the first 2 lines that in Italy, up to the 6th of April, we had only 2,050 children that were infected with COVID-19, and this number are very similar to those reported in China. And these account for 1.3, 1.4% of all the patients that have been infected with COVID-19. In the upper part of this table, you see that most of the kids that have been infected are children from 7 to 17 years of age, but on the right, on the lower part of the tables, you see that children that are more often hospitalized are those children with under 1 year of age. But our experience is that almost all the patients that are infected, the children that are infected with the coronavirus 19 virus, have a very mild disease. This is a study, there are several studies coming from China on pediatric cohort. This is a study reporting data from 2,143 pediatric patients with COVID-19, seen between from January to February. They have a positive swab for COVID 2019. Under the clinical point of view, they report the data of 2,143, but among these 2,143, only 731 patients had were confirmed cases, have a positive swab. The other cases were suspected on the clinical ground, but they didn't perform the test. But they analyzed all the kids together, and the median age of the patient were 7 years, ranging from 2 to 13 years. 56% were males, and 94% of the patients were asymptomatic or a mild or moderate case. The median time from illness onset to diagnosis was only 2 days. What is interesting that among the 2.9, only 2.9 children of this big group of patients have a severe COVID-19 infection. And as you can see from the slides, the more severe kids were children less than 1 year of age. But we can say that this study may have a bias because in this analysis they consider all the patients, so also those patients where they do not look for a virological etiology. This is another study where they look for pediatric cases in 72,314 cases, and less than 1% of the cases were children after the 10 years of age. So there were 1,391 patients that were infected with COVID-2, and only 171 patients were confirmed with PCR, and the median age of this infected children was 6.7 years. And here you see that most of the patients come from a family cluster or confirmed family members, and 50.8 were asymptomatic, have asymptomatic infection, almost 20% an upper respiratory tract infection, and 65% have a pneumonia. The most common symptoms were cough, pharyngeal erythema, fever, nasal congestion, tachypnea on admission, and tachycardia on admission. And the 9% of the kids also have vomits and diarrhea. So in children, especially, this virus can give gastroenterological symptoms. And here are reported the most common ground glass findings on high-resolution CT scan. So now the question is, always from this study, 3 patients required intensive care support and invasive mechanical ventilation, and all the 3 children have a coexisting condition. One had hydronephrosis, leukemia, and intussusception, and the only one that died was a 10-month-old child with intussusception and died 4 weeks after the admission. All other children recovered completely. So now the question is, okay, this is the clinical picture that is very similar to adults. You can have a symptomatic infection. You can have a child with mild symptoms. You can have a child with moderate, non-severe pneumonia. You can have children with severe picture that can have also gastrointestinal symptoms like diarrhea, and you can have critical patients. So in conclusion, we can say that from the China studies that all children at all age are sensitive to COVID-19. There is no difference in gender. In children, clinical manifestations are very less severe than in adults. And there is a strong evidence for human-to-human transmission. But the question is, why children are less infected than adults? And this is very interesting, especially because we all know very much that children, especially when they have less than 5 years of age, very commonly have a viral respiratory infection. And that respiratory infection, or viral respiratory infection, are much more common in children than in adults. We suppose that fewer outdoor activities and they'll have less international travel, making them less likely to contact the virus. There is a more modulated innate immune response because they have more vitamin D. They have an healthier respiratory tract because they have fewer underlying disorders. They have not been exposed too much as cigarette smoke or air pollution as adults. We have recently published in our group a review on while with the title of "Will Children Reveal Their Secret? The Coronavirus Dilemma." In this review, we try to see from the literature and from what is written about SARS, which could be the immunological reason why children have less severe and are less frequently infected than adults with this virus. And what came out from our search is that there are 3 reasons why kids can be more less severe and less frequently are infected with COVID-19. First of all, because it has been demonstrated that children have a more a higher concentration of ACE2 receptors, and this is in a way controversial because ACE2 receptors facilitate the infection because I told you that are the receptors of the virus, but in a mean way, the ACE2 receptors, the metabolite of ACE2 receptors are very important against to defend the lung. So the dilemma is that the children have a higher concentration of receptors, but if you have a higher concentration of your receptors, you can defend yourself better. Another important point that children may have what we call trained immunity. Trained immunity is a consequence of immunization. We all know that kids receive a lot of immunization, like immunization against measles, in African country against TB. And what has been demonstrated that when you receive immunization against measles, you can mount a bigger amount of immune antibodies production, not only against measles, but also antibodies that cross-reactive against other infection. And these kids that receive measles, mumps, and rubella immunization, they can have also innate immune response, interferon gamma immune response, that is more active than adults. And finally, we all know from normal values that kids have constitutionally an elevated number of lymphocyte B, T, and natural killer. And this is the reason why probably after the trigger with viral infection that they have during the first year of life, they have a constitutionally a higher number of lymphocytes. And it's well known from this data coming from China that the patient with the more severe COVID-19 infection are those that have a lymphocytopenia. So another important point is the mother and feeder situation. There are several data, several reports from neonates born from mothers with 2019 coronavirus pneumonia. This is a study on newborns born from a group of mothers, and you see that 4 were full-term infants, 6 were born premature, 2 small for gestational age, and 1 was a large for gestational age infants. And this paper reports that the fetus, the child, the neonates may have a fetal distress. The mother may have premature labor. The child may have respiratory distress. They may have thrombocytopenia with abnormal liver function and even death. But it has been demonstrated so far a vertical transmission of the virus from the mother to the child. So all the kids, all the neonates were negative to the virus. And so what the neonatologist should know to go, I almost finished, should be considered risk population. They must wear protective equipment. The child must be isolated. They should not breastfeed, and there is no vertical transmission. Treatment. There is no immunization against COVID-19. There is also symptomatic treatment. The most common complication is acute respiratory distress syndrome, followed by acute heart injury and secondary infection. So the treatment is only empirical. You can try some antiviral therapy and some systemic corticosteroid. You use the systemic corticosteroid in the most severe cases when you have a cytokine storm. These are the 2 antiviral treatment that is most common use: interferon alpha nebulization and 2 antiviral, lopinavir and letonavir. It just came out a study in 200 adult patients with a COVID-19 infection, and there was no improvement in mortality. So there are no antiviral that are shown to be useful. I just wanted to finish my lecture with this study that I think it was very important. This early clinical trial conducted in China with chloroquine. And they demonstrate that the hydroxychloroquine is more effective than chloroquine, that it has a significant effect in clinical outcome and in viral clearance. These are the graphic of a patient treated with the chloroquine and with the hydrochloroquine, and you see there is a reduction of positive samples, and the results were even better when they add azithromycin. So what we are using, very common now in Italy, in patients with a COVID-19 infection, is a combination of hydroxychloroquine and azithromycin. Thank you.
بسم الله الرحمن الرحيم. طبعا أنا بشكر بروفيسور فابيو ميدولا على البرزنتيشن اللي أكتر من رائعة، أعتقد فيها كمية informations كتيرة جدا. I'm trying to focus about certain issues. Maybe I will bypass a lot of informations which may be repeated to skip what is repeated. Okay. First of all, I want to thank all these international pulmonologist consensus that will make a task for them to make a consensus about the COVID-19 with a lot of well-known professors worldwide. And I think that there are three requirements must be satisfied to ensure an infection of an individual host. First of all, we are in need to get sufficient virus which must be available to initiate infection. Second is that we should have cells at the site of infection which must be accessible, susceptible, and permissive for this virus. And also we should have some sort of ineffective, defective, or absent local host antiviral defense in order to initiate an infections. We have a lot of virus-dependent and host-dependent factors which totally all in all give the final form of the disease. Is it mild, severe, with complications, and also affect the transmission rate and the death rate. First of these is virulence of the virus, which can be quantified by many measures or parameters. One of these is to measure the concentration of the virus, which causes 50% deaths or paralysis or infection of the organism. So what we can say, the lethal dose 50 or paralytic dose 50 or infectious dose 50. Secondly, the amount of the inoculum of the virus. So in one of the well-known research that we have a positive correlation or proportionate positive correlation between the dose of rhinoviral infections and the severity of manifestations. Also, the speed of replication of the virus, which significantly related to the acute onset of manifestations. For example, in influenza virus, the incubation period just 1 and 2 days, so the speed of replication may be a little higher than for COVID-19, in which the incubation period may be a little bit longer. It may last between 2 and 14 days. The fourth point is the viral spread is that if we have the viral infection is localized at the site of infection, or it may spread for other cells, either neighboring cells, or it may pass systematically, like, for example, if we compare to measles, which can be considered as a multi-system affected disease. The host-dependent factors, which are very important factor in which we get marked discrepancy that based on the immunological state of the patients, if the patient is immune competent or immune compromised, and also the nutritional status, which can be considered a sort of secondary immune compromisation, and they can affect the severity of manifestations. Also the age, sex, and weight. We see all of us that male a little bit, maybe 1 in 5 more affected, 1.5 more affection in males than in females. Also the age, we have much less affection in young children, while we get a very higher rate of affections in the older age. Also based on the specific cellular receptors. The final issues is the environmental factors, which play, I think, that a significant role also in the spread of the disease, like pollution, like climate, like crowdedness, so we can get more spreading of the infections in the more crowded populations. Coronavirus, as Professor Fabio said in the presentations, is belonging to Nidovirales, in which Coronaviridae is the big family of that of the coronavirus, in which we have 4 genera: alpha, beta, gamma, and delta. We know that alpha and beta are living, they are zoonotic viruses, and they are living in mammals, and may need intermediate host in order to be transmitted to the to the humans. Still now we have no gamma or delta coronaviruses affecting human being, and these form of the viruses are living in the birds, but some of them may be infecting some of the mammals. Since 1960, we have more than 2 viruses, which is 229E and OC43, and they are discovered since 1960. Then we get NL63 and HQ1. I think that they are discovered in 23 and 24. And sorry, not 3, 13 and 14. And these viruses are responsible for more than 15% of the upper respiratory tract infections, and they be considered as the second most common cause of upper respiratory or common cold after rhinoviral infections. However, for SARS, which was discovered in 2004, and Middle East respiratory syndrome, which is discovered in 2012, I think that these are the starting of change in the genetic form of this, and we know that we have an intermediate host like camel for Middle East respiratory syndrome, or cabbage cat for the SARS, and for the SARS-CoV-2 till now we don't know the intermediate host. It is snake or pangolin, which is one of the wild animal which can be eaten in China. Simply that we know that this virus is positive single-stranded RNA in which we have many spike proteins. We have many nucleoproteins and spike proteins, which is one of the very important antigenic structures on this virus, which can be subdivided into S1 and S2. S1, which is a little bit more simple and more similar to the SARS virus. That's why both of them, they considered ACE2 receptor, which is the same receptor for SARS, is also the same receptor for the COVID-19. And through 103 phylogenetic analysis of the SARS-CoV-2, they found that we have 2 types of SARS-CoV. The L1, which representing about 70% of cases of SARS in China, and we have another one which is SARS-S or SARS-CoV-2-S, which represent about 30%. Then they consider this one maybe is present outside China more. So we have 2 types. Actually, we have no research till now discussing about the discrepancy on the clinical severity of which of one. So till now we don't examine, or we don't know which one is more severe, if there is any differences in the clinical manifestations and severity and the complications, rate of spread of each virus and the other. As Professor Fabio discussed this, which is also very important, that the ACE2 receptors are the receptor for the S1 or spike receptor of the virus. And we have different SCE2 receptor variants worldwide. So we have discrepancy between this SE2 receptor between Asian, between European, between African, between American. And so this is one of the issues that it may play a role, the genetic variants of the ACE2, which may play a role in the clinical severity of the disease, and also the rate of the spread or the transmission rate of the virus between an area and the area. And this is one of the very important issues that we are in need to be a point of research in the upcoming few months to assess if ACE2 receptor play a major role in that. And also, as Professor Fabio said, that it may also explain why we have more male affection and why we have less children affection. About the epidemiology, the mode of transmission of the virus is very important. It is person to person and spread also from contact with contaminated surface. We should know that the person-to-person spread is the most important form of transmission of the disease, and the spread from contact with contaminated surface or objects, they have a very less important mode of transmission, and we should consider and focus about the person-to-person transmission. Actually, respiratory infections can be transmitted through droplets infections, and we have two types of droplet infections. The respiratory droplet infections, which about 5 to 10 micron in diameter, and this type of respiratory droplet infections represents the main form of infections, and in one of the analysis of a very huge study, they prove that the respiratory droplet infections are the main source of transmission. And these can occur through talking, sneezing, coughing, and landing of these droplet secretions, which contain the virus, on the mucous membrane of the affected recipient patients. When these landing on the mucous membrane of the mouth, the nose, of the conjunctiva, and this is the main source of infection of coronavirus infections. However, indirect contact with the surface, as we said, that it plays a minor role. It is not the major role of transmission, so we should focus about that. The main concern about the droplet nuclei, in which we have droplets which contain microbes and they are less than 5 micron diameter. And however, these can stand in the air for a longer time. They may stay in the air for many hours or even longer duration. And however, we have a very big concern, whatever the WHO, the CDC, the American Academy of Allergy and Immunology also, they have a very big concern about if this disease can be transmitted through the airborne transmission or not. We have no confirmation till now about the airborne transmission or not. But for sure that airborne transmission may be possible in certain circumstances, and for all the doctors, that you should know that any flexible endoscopic procedures or endotracheal intubations or open suction or using nebulized medications, manual ventilations or non-invasive ventilations, tracheostomy, and the cardiopulmonary resuscitations, they can be a very big and important source of transmission. And so using the PPEs for the doctors is a very important issue for preventing to catch up this disease. And as Professor Fabio said, they have a very huge number of the medical staff will be affected by this disease due to not taking all the PPEs measures that should be used during contacting patients with COVID patients. However, the shortage of these PPEs may be the cause, and this shortage is worldwide a very big issue for preventing the disease. Professor Fabio commented about no reports about the fecal-oral transmission, especially in children, and that one of the study is saying that the isolation of the virus from the feces, but till now we have no confirmation about the fecal-oral route transmission that we can confirm that or can be used as one of the way or sure way, and still now we have no evidence-based way of transmission. Professor Dr. Fabio discussed about the pregnancy, and so I will bypass this, that about the vertical transmission or the prevention of or transmission through breastfeeding or something like that. But most of the health caregivers should take the decision or the cost benefits between to continue breastfeeding or not. But most of the CDC currently recommendations that you should isolated the mother from the baby to avoid neonatal transmission of the disease. The period of infectivity of the disease also is very important to know that. However, most of the studies depends on the diagnosis of this disease is the presence of PCR in the nasal secretions. However, this is not by any way, we can't prove by any way the presence of PCR in the nasal secretions, whatever nasopharyngeal secretions or pharyngeal secretions. This is not a documentation that this patient have a disease itself, for sure, because he may be a carrier, but this is not a definite proof that he had a secretion. So we may get some sort of misinterpretation of some of the data. Then Viral RNA level also in the upper respiratory secretions appear to be higher after the symptom onset. This means that we have a lot of patients in the incubation periods or in the pre-symptomatic stage that may be infectious to the others. Also, there is a big problem that if the concentration of the virus is low, it may give negative results. Also the transmission that might be likely earlier in the stage, which is very important. The duration of viral shedding, I think that Professor Fabio commented about it. This disease is characterized by a very long period of viral shedding. And so the patient, and then the patients may last for average in 90% of cases, the viral shedding may last I think that the transmission أيوة سامعني؟ كويس. What about the percentage of carriers are asymptomatic? This is a very important study which is done on 3,700 passengers and the crew of Diamond Princess cruise. We can find here that about 46.5% of the infected people have no symptoms at the time of testing. But if you continued more, that this is a very primitive evaluation that about half of the patients are definitely asymptomatic. But when you are following these patients in the upcoming days, you will find that 28.5% becomes asymptomatic. So these patients, we are saying that they are pre-symptomatic, and only just 18% of the patients are asymptomatic. In Iceland, which is one of the very important study that done testing a large segment of populations, they found about 50% who tested positive are asymptomatic. However, this reflects how much asymptomatic people are present in the environments. And also, we have a very important mathematical epidemiologist who estimated that the symptomatic people may be 30 to 40% worldwide. And also the CT director, Robert Redfield, he told that about 25% of the COVID-19 are asymptomatic patients. We should know that how COVID-19 is contagious. So if we compare simply to influenza virus, we can find that the influenza virus incubation period is about 1 to 2 days, compared to 214 days of COVID. So for how long the patients can transmit or spreading, or we get viral shedding for a very long duration for COVID-19, if we compare it to influenza. So it is very important to all of us. Also, the basic reproduction number for infection for influenza is much less, is about half or less, or even 1/3 of the case in COVID-19. So after 10 rounds, the influenza patients can transmit the disease after 10 rounds into just 56 people will be sick. But in COVID, after 10 rounds, you can find that about 2,047 people will be sick after 10 rounds. So how huge this COVID-19 will be contagious if compared to influenza virus. Also, for the hospitalization for influenza virus, the hospitalization rate is about 2%, compared to 20 to 31% of patients with COVID-19, which is about 15 times more than influenza virus. The fatality rate in influenza is just 0.1%, if compared to the fatality rate in COVID-19, which is ranging between 1 to 3%, and sometimes maybe even 5, 6, 7, or even more in some countries. As regard the influenza, we have an immunity through vaccine, so herd immunity, but till now COVID-19 is a prime. It is a new vaccine with no previous immunity against it. However, we expecting that about 20 to 60% of the world population will get this infection in the upcoming few months. I'm trying to make some comparison between Egypt and Italy as regard the mobility changes, because as we know that the physical distance between Egypt and Italy, I think that during the last months we have complete or even 100% physical distancing, which resulting in retail resection by about 94% in Italy compared to about 50%, because in Egypt we have just 50% reduction in the physical distancing. And so we get even 50% resection. As regard the pharmacy, we get a reduction by 24% compared to 85%. For the transient station, we get 52 reductions compared to 87 reduction in Italy. As regard the parks, we get 90% reduction compared to 40% in Egypt. And for the workplaces, we get a reduction by 35% in Egypt, while get reduction by about 60% in Italy. And definitely for residential staying, we have 24% in Italy compared to 15%. And so we can imagine how physical distancing, which is very important for protection against the spreading of this disease, and again, for decreasing the rate of hospitalization and the capacity of hospital management of such cases. In Egypt, we can say here that, so this is a referral to Professor Hisham al-Askari, is one of the well-known eminent figure in Egypt. He did this study that we can expect. This study was done on 6th of April, and we can see here the cumulative confirmed cases in Egypt on 6th of April, and how they can expect how many cases that can be in the upcoming few days. And you can see here through the logarithmic cumulative confirmed cases also in Egypt that we can say we have two model done on 5th of April and one on 6th of April, that on 9th of April, yesterday, he expects that we will have 1,776 patients, but actually we have 1,699. And that done on 5th of April, he put an expectation about 1,635 on 9th of April, but the actual number is 1,699. So we have just a very mild shift of this model, which can be expected. And also we can hear that through the after license from the European Space Agency to Egypt for social distancing. This is an example how social distancing in Wuhan can lead to marked reductions of the crowdness. This can be measured through the concentration of nitric dioxide and monoxide, and he can through some of the sensors can detect that, and how in Wuhan we get marked reduction of this and the importance of physical distancing about this. However, in Egypt, but this is before the applying the reduction physical distancing by 50% in March 22 and 23, how we have a very crowded populations like Cairo, Alexandria, in Kafr Sheikh, all the northern areas, we get also a little bit marked reduction in south of in the Red Sea area and in Upper Egypt. I don't want to be recurring many of the titles and topics, as Professor Fabio said. This is one of the very important informative data from the disease of control and the prevention. the Chinese Center of Disease Control, that we can see that about less than 1% of the patients in young age is affected in children between less than 10 years of age, and also between 10 and 19 years of age, if comparing this number for the other populations. However, this is not exactly differs, because also SARS-CoV and Middle East Respiratory Syndrome, definitely children, in all of them, are less affected, and so this is not strange for the SARS-CoV-2. We get in SARS-CoV 2 to 4% only of children are affected, compared to 1 to 2% only in SARS-CoV-2, and the same as for MERS. And the incubation period may be more or less the same for all, but the case fatality completely different from SARS-CoV-2, which is about 3% compared to 42% in Middle East Respiratory Syndrome and about 11% in the SARS-CoV. This is the presentations, and as Professor Fabio said, we are classifying the manifestations in pediatric age into asymptomatic, mild upper respiratory symptoms or mild pneumonia. Severe pneumonia is one of the very serious problems that need in most of the cases for ICU admissions, and for the critical cases in which the case fatality, which may reach up to 40 to 50% of the cases, or 48% of cases. And the case fatality in cases of severe pneumonia may reach up to 14% compared to adults. As regard the serologic test, which discussed by Professor Fabio, we have two types of serologic test. Yes, the rapid antigen test and the rapid antibody test. Actually, the antigen test is not yet well available in the market till now, and I think that they will make a big change in the market if they are available, because they will facilitate a lot how you can screen a lot and the huge number of patients with low cost. But for the antibody test, I think that it is not yet well recommended to do serologic test, and this is due to the short stay or the short time in which we can find IgM and IgG. IgM is just positive in the blood just for less than 10 days, just 8 days, and also the same for IgG, which cannot last more than 30 to 35 days or even 40 days. And the onset of IgG level usually started late, and we can say starting here from the 8 to 14 days after the onset of manifestations. That's why the FDA has warned not to use these tests yet by any way to implicate authorization or final decision that this patient had an infection or not, or even to assess that he is immune or not, because the duration of the IgG is not staying in the blood for a very long duration. So it will give, till now, the problem is a big. Also, another point is that the risk of cross-immunization with other coronaviruses that may affect the positivity of this test. However, many studies done to check that if we have cross-immunization between other coronaviruses and COVID-2, but actually are few numbers. We cannot get an evidence-based confirmation about the presence of cross-reaction with other coronaviruses, and this is also an important issue. The PCR is the most important test, which by which we cannot confirm the diagnosis except by PCR, but we should know that the samples are usually taken from the nasopharyngeal secretion, oropharyngeal or oral secretions, and you can do it through also the bronchoalveolar lavage or tracheal wash, and the lower tracheal secretions are much better than upper, the yield of the results is much higher from the lower respiratory secretions rather the oral or pharyngeal secretions. The specificity, as Professor Fabio said, maybe 98 up to 100%, but it is less sensitive the sensitivity may reach between 50 to 67, 76%. It differs from study to another. But maybe if you added the immunologic studies, I think that the sensitivity may be a little bit higher if it is used with PCR testing. A new FDA approved the COVID-19 instruments by Abbott also starting to be on work in USA, and is examining more than 20,000 up to 50,000 patients per day, using also genetic study from the saliva. I think that also it may give a clue during the upcoming few days and weeks for using these apparatus. Professor Fabio discussed the imaging and its importance, and how X-ray is very important starting early in the disease. But usually in the start of the disease, you may find normal X-ray and you may not get any X-ray abnormality at the start of the disease, but you will get abnormalities about 60 to 80% of the hospitalized patients. So we should know that. But for the CT finding, we can specify that we have early versus late manifestations. And we have the Radiological Society of North America consensus, and also the Radiological British Society simplify the manifestation into classic finding, probable finding, and the intermediate finding and non-COVID finding. However, the presence of bilateral multiple peripheral lower manifestations, as we can see here, grounded glass opacifications, or reverse halo, or crazy paving consolidations, all of these findings are highly suggestive, or even you can use it as one of the sample tests for a sample diagnostic criteria for COVID-19. And in China, early in the disease, many patients who had this CT finding, they are considered have a disease till the PCR is available, or sometimes the PCR early may be negative, and just to get confirmed results after doing the CT of these patients. The bronchocenteric consolidations and the irregular nodules also are found of probable cases of CD of COVID patients. The reverse halo pattern, as we can see here, is also one of the findings that if you can see it in the CT, you can justify that if this patient have a probable case of CT, grounded glass opacifications bilateral, and if you have normal CT, usually you can say that you can confirm that. And thank you for your following this presentation. And I think that we are passing the presentations by the time available by 15 minutes. Have 4.2 of the total populations. We have 6.2%, because in 0 to 12 years, 0 to 10 years, we have 2.1% of the total numbers. Now we have 1,605. 2% of these numbers are below the age of 10, and we have 4.2% between 10 and 12 years. So all in all, till below the age of 20, we have 6.4% of the total number.
So it means that you have 50 patients, around 50 patients.
Yeah.
And are they
65.
55. Are they in intensive care unit, or they are mild disease?
No, none of them enter the ICU units by any way. All of them have mild symptoms. Only nobody of them. We have no death rate at that age by any way. None of them enter the ICU, and most of them have mild symptomatology, except few of them have pneumonia.
Yes, because what I can tell you from our data, the data that I show you about Italy, those are confirmed COVID-19 patients. So the mortality rate is according to that number, But at the end, it's much less, because we are calculating that we have 10% more patients because that stay at home, that they do not go to the hospital. So at this point, we think that in all Italy, we have more than 1 million of patients, and the mortality rate is less than is around 5%. It's much less if you consider all the patients. And in children, we don't have patients in Rome. In my hospital, we are testing for children with COVID, and we do not have patients. We do not understand if because we are not able to detect the virus, or because really they are not infected. In Bambino Gesù of Rome, that is is a big children's hospital, they have only 7 patients, and they come from all the region of Lazio, and none of these kids is very sick at the end. So children are very are not infected too much. It's not really a big problem for children in Italy.
For sure, definitely the same as in Egypt, although the total number as a percentage-wise in children in Egypt is a little bit higher compared to the percentage in any other country. But the manifestations, as you said, very mild. None of them enter the ICU, and there is no death rate till now, which is confirming the same data for with other companies. I think that I asked Ahmed Kantar also in Bergamo, and Professor Renato Cotrera also in Rome. He told, I think that he confirmed the same as...
because in Bambino Gesù, they are followed by Renato, followed by another doctor. They have two hospitals, one in the downtown and one outside, and the infection children are hospitalized in the hospital that is outside Rome, and there are only 7 as far as I know, and all 7 with a very mild disease.
But we have an important question. Are you doing PCR test at ease for any persons, or you have limitation for doing PCR for some of the patients?
We have limitation. We are limitation. We are doing
limitations for the cost of that, the cost of this, or limitation of the availability of this.
Oh, it's the cost. It's the cost.
Cost. Yes.
Cost, and so we do the policy of our region is to do the test only to kids that we think that should be hospitalized, so that they have severe symptoms. Otherwise, we send home the child with and they have to stay at home at least for 14 days.
But I have an important question for you, Fabio. I asked you before, you are doing what you are doing for patients when you are admitting the patients in the hospital. You told me that for any patients that will be admitted, you told me that you are doing PCR for that patients before admission.
Okay, there are two main reasons. First of all, we have 2 different pathways when they arrive to the hospital. For those kids that have respiratory symptoms and where we suspect COVID infection, and we have a different triage and a different way for those kids that come to the hospital with trauma, with wound, or if they have epilepsy. So they do a different way. In all the kids that we think that are hospitalized, COVID positive or non-COVID positive, we do the test to the child and to the mother, because we want to be sure that if we go inside the hospital, they are not infected. But if there is a child with mild respiratory symptoms or with mild other kind of problem that they should go home, we do not do the test.
Please, I have also another important question. Now in March and April and May, this is the springtime, and this is the actual time of high rate of other viral infections, rhinovirus, maybe RSV virus, and other viral infections, which give the same similar manifestations young children. So what you are instructing all the pediatricians, how they can deal.
I tell you what is happening in Italy.
Yeah.
We used to have more than 150 children a day in our emergency room. Do you know how many children we see now? No more than 10. And we have no infectious disease at all.
Due to the physical distance, yeah?
They completely disappear because the schools are closed. Yeah. Because you have to stay at home. You don't go around. You have the mask in the face. So there are no infectious disease anymore. And we are doing a study in children with lung pneumonia. And so we were collecting the data from all the kids that arrived to our hospital with the diagnosis of pneumonia. And until 97% of the kids were hospitalized from October to the beginning of restriction. After restriction, we had only 3 patients. So now our hospitals are completely empty. We have no patient in the emergency room. We have no patient in the hospital, hospitalized. So we have no more than 10 children a day.
Okay, very good. I have here a question, Professor Fabio, that the value of IgG marker doesn't mean immunity.
That is very difficult to answer. It's a good question. I mean, there are no immunological tests so far that have been accredited in Italy, and but we think that if you will have a good immunological test, the presence of IgG, it means that you have the immunity. That at least but they should be very specific for COVID-19. This is the reason why the tests that are going around are not useful so far, because they are not specific for COVID-19. But
definitely, in my country, we have what we say rapid test. These tests, including both IgG and IgM. Yes, and this is specific for COVID.
But in Italy, it's not accredited yet.
Yes, definitely. And this is, as we say in the presentation, this is not FDA confirmation that these tests, can you rely on it? And it doesn't give any idea about that you have herd immunity, because you may have a cross immunization with other coronaviruses, and the duration of the IgG level, it may not last more than 35 or up to 40 days from the onset of manifestations, and may decline. And so you may give a false impression about the actual situation. So you have no any confirmative data about the value of this test. But we have another question. What about the mechanism of binding of virus to hemoglobin? Professor Fabio.
So what I know is that at the moment, the specific receptor for the virus are ACE2 that are mostly on in all the cells of the body, and mainly in the alveolar type 2 cells. And these are the specific receptors for the virus.
But we have some papers recently that saying that we have also some receptors for the virus which can cause dissociation of the hemoglobin, beta globin chain to the oxygen. So he can be the cause that we have severe hypoxemia due to losses of oxygen from the yes, from the hemoglobin. That's why most of these patients who are going to RDS, they are not responding to even higher oxygen level. And they try this paper to explain that. I have a concern about this paper because you have a lot of theories that can explain why these patients are not yet improving, and I think that the circulatory microthrombosis.
Yes, you can have a microthrombosis.
Yes, I think that this is can explain that clearly. But the main problem is that most of these patients usually get these manifestations dramatically with abrupt onset and sudden onset, while before that they are in a good situation.
So,
and,
so you think that this can be the mechanism because it's very rapid?
Yeah. Why it occurs? Because these patients, or most of these patients, they are going well, and then we get sudden, rapid, abrupt onset of deterioration, which is not yet, and they're starting by the between 8, 10, or 12 days, you get these manifestations, while just a few hours before, he is a little bit good and not so bad like that.
That could be, but I think that the cytokine storm is one of the reasons why some of these patients have severe manifestation. It's more hyperinflammation. That is, I think, that is the major reason. The fact of thrombosis is very difficult to demonstrate. And what is clear to me that many lung disease are a consequence of hyper reaction, that an hyper than hypo.
Yes, okay. This is a good explanation for that. We have another question about that if any person can capture a second time infection.
Okay, this is not really very clear. There are some data from China that they have new cases, but it's not clear that you can get it a second time. It depends. Yes. It depends on the variability of the virus, because if the coronavirus is similar to RSV, I think that you can get it very, very often.
Yes, also there is another important question, is that how to deal with a newborn to mother with COVID-19?
You should take, our experience and the experience that is coming from the literature, when you have a mother that is a COVID-19, you have to take all the measure to avoid the spread of the infection. So the doctor, the nurses have to dress up with all the medical device to prevent the infection. The neonates should be put in a room isolate, so a specific room for this kind of patients. And fortunately, there is no evidence of a vertical transmission of the infection. So you should treat the neonates exactly like all the other neonates. Only if they have problem, you have to treat the problem.
Yes.
There is a little discordance of breastfeeding, because there are somebody that consider to avoid breastfeeding because you can the neonates can get the infection from the mother, and there are other people that say that you can breastfeed. So it's not clear that.
Yes, there is an important question that he said that just missed. How come children have higher ACE2 yet not severely affected?
Because there is it has been demonstrated that there is a metabolite of ACE2 that is angiotensin 117 that is produced by the ACE2 once a virus gets to the receptors, that have a favorable effect on the lung. So reduce the pressure, reduce the permeability, reduce the inflammation. So at the end, to have an increased number of ACE2 receptors that has been demonstrated in neonates. I mean, there are studies on rats that show that the number of receptors are decreasing from birth to adult. At the end is a protective effect because the metabolite is a protective for the lung. The angiotensin 117. This is the name of the metabolite.
Also, some persons asking about what about microthrombi? We said that before, the future and the manufacture of a vaccine to COVID-19, what is the difficulty for doing that has the virus? He is asking about the availability and the success of the vaccine.
There are no vaccine at the moment, and to produce a vaccine, you need a lot of time. If you think about the vaccine against RSV, it's more than 60 years that are working on that, because the first vaccine were developed in the early 1960s, and it was a disaster. And since 1960, they're trying to develop a vaccine against the virus. So I think that before we'll have a vaccine, it will take quite a long time. And it depends on the variability of the virus. It depends of the virus.
So many thanks, Professor Fabio, for this presentation and the informative data about the COVID-19. And I think that we get a lot of information from you, and many thanks. And also I want to thank the European company for this informative presentations about COVID-19 and the updates, especially in children. And I hope that it will be of adding points for all of us. And again, thank for Europea for this webinar.
Thank you. Thank you.
يا جماعة المفروض ان انتم في تقدر تعمل برنت اوت للسيرتيفيكت بتاعتك بتاعت الحضور من خلال من خلال الويب سايت اللي حضرتك بتشوفه. يعني من خلال الويب سايت تقدر تدوس على زرار تقدر تعمل برنت اوت، هتجيلك في خلال نص ساعة. هتجيلك السيرتيفيكت تقدر تعمل لها برينتنج اوت. هتملى الايفالويشن في خلال نص ساعة، هتلاقي بإذن الله السيرتيفيكت جايه لك بإذن الله. شكرا جزيلا، أشكركم جميعا، والسلام عليكم ورحمة الله وبركاته.